All this is Dr. Mobeen Sayed on drbeen.com. Welcome to one more show. So this is for the first time today. We have two rock stars together. We usually have one panelist with us. So today we have Dana Parish with us. I'll introduce her in a second. And we have Dr. Stephen Phillips. I'll introduce him in a second as well, although I believe you know both of them very well. So first of all, welcome Dana and Stephen.
Thank
Thank
you.
you. It's great to see you.
So thank you very much for being here. Thank you for being with the KoolBeens here. So, very quick introductions. Uh, Folks know Dr. Stephen Phillips before. He's been here a couple of times. Dana's bio is that Dana Parish developed Lyme-induced heart failure as a result of being improperly diagnosed by some of the best doctors in the country and had her life saved by Dr. Phillips, a chart-topping singer songwriter for Sony Music Publishing, who has written songs for superstars like Céline Dion and Idina Menzel. She has become a powerful voice for change in the field of Lyme disease. She lives in New York City. Dana, thank you so much. One, you have been a patient of this disease. Then here you are, of course, I believe, much more recovered than where you were. And then you worked with and joined hands with Dr. Stephen Phillips to put this book together. So thank you very much for doing this. And I want to quickly show the book before I ask you more about yourself. So one quick second. So KoolBeens, here is the book. You have seen this book before. I have requested you to buy this book as well. I have never requested you to go buy this thing or that thing. This is the one book that this is the third time I'm going to request you once again to keep it with you. I went through this and it was enlightening for me. And I looked at some of the pieces and I said, oh man, I should have been aware of these things for myself and for my patients. So, similarly, I would request you to have this book with you at all time. Give it in gifts to the folks who may be at risk of chronic diseases or have chronic infectious diseases. So, this is the book. The link is in the description as well. This is a talk by Dr. Phillips, so we'll talk about that in a second as well. So, Dana, before I introduce Dr. Stephen Phillips, tell us a little bit about yourself.
Yeah, so first of all, thank you so much for your incredible support for our book and for the two of us. So my story is I was at the prime of my life. I was just on the heels of signing a brand new publishing deal with Sony Music, which really was a dream come true. And I had just written 2 songs for the new Céline Dion record. And, you know, I mean, you don't get any more exciting than that when you're in my world of being in music business, writing pop songs and being a singer and getting to work with all these amazing people. So about to sign my deal, I go to my friend's wedding in New Jersey, and I come back and I get out of the shower a couple days later and I see a little bite and a little rash. I can't call it a bullseye because it doesn't really look like a bullseye for many people, including me. Just looked like a little red rash around this bite. And before that, I had severe crushing headaches and neck aches for a couple of days. And I was like in this deep coma-like sleep. So it was like a flu-like syndrome. But by the time I saw the bite and the rash, my initial symptoms had pretty much resolved. But I grew up in New Jersey, so I knew the basics about Lyme. I knew that looked like Lyme to me. So I went to the urgent care around the corner, and they gave me 3 weeks of doxycycline, said it was Lyme. That bite and rash or bullseye is a diagnostic tool. That's all you need. There is no early test for Lyme disease. So that's a really important thing for people to know. If you have that, you have Lyme, and you're given a couple of weeks of antibiotics. And what I didn't know at that time was how often those 3 weeks of doxycycline fail. And so my initial illness, as I said, resolved. The doctors in the urgent care told me, don't worry about it. It's really not a big deal. Don't Google it. That was something else that I found very, very strange. they said, don't Google it because then you're going to see all these crazy Lyme people. Well, I had never heard of a crazy Lyme person. I didn't know anything about this whole controversy and this whole denial and strange, behavior around this very common infectious disease. I had no clue. So I wake up in October. So this was like July 4th weekend. I get through the antibiotics. I'm tired, but other than that, I feel like basically okay. And then I wake up in October one morning out of nowhere and my breast is swollen. And from there, I went on to get severe crippling weakness, body pain, rashes, visual disturbances, light and sound sensitivity, like a lot of my hopes and dreams to go and be working with all these amazing artists all over the place were kind of crushed because I couldn't even walk down my street by myself. I was completely debilitated. I also had extreme sudden onset anxiety, depression, and insomnia. So I went to 12, top New York City doctors, and everybody said it couldn't possibly be related to the tick bite. I mean, I kept saying, well, the only thing that's different is that I got this tick bite and I got really sick over the summer. And that's the only thing I can think of. And my body doesn't feel like my own anymore. And my brain doesn't feel like my own. I don't really have another explanation for this. And they all said it couldn't possibly be the case. I was diagnosed with fibromyalgia, arthralgias, which are like joint pains. I was given all these diagnoses that don't actually speak to the underlying cause. They just are a description of your symptoms. So it wasn't helpful. And I just kept getting medicines thrown at me. And it felt incredibly wrong. So I kept pressing. By December, by Christmas week of that year, 2014, I went to my friend's farm in California to just try to rest because basically all the doctors concluded that I was just really stressed. And I know that sounds very familiar to people who have gone on to have long COVID or chronic Lyme or whatever. And I Googled all my symptoms finally. I was scared to do it, but I Googled every single one of my symptoms. And I came up with this checklist right away. This doctor who retired named Dr. Joe Burrascano, he had a Lyme checklist. And I had something like 38 or 39 symptoms on this 60 symptom checklist. And I was enraged beyond words because by then, what I didn't know was that I was in heart failure. Now, I was very breathless. I didn't know why. I really definitely felt like I was dying. Every system of my body was deteriorating. But I came back to New York. I went to a cardiologist, found out I was in heart failure. They said I had the heart of a 70-year-old man. They didn't know why. And at that point, thank God, a friend of mine had heard Dr. Phillips speak at some hearing where he got a law changed about for patients for chronic Lyme, and he can elaborate on that because I wasn't there. But they told me, if any of us got this, this is the only doctor that we would see. So I got an appointment. Luckily, I got in on a cancellation, and he saved my life. And he recognized right away that not only did I have Lyme, but nobody, I went to 3 infectious disease doctors and they never looked for any other vector-borne diseases. And, when Dr. Phillips worked me up, he had a suspicion clinically based on my symptoms that I had other stuff going on. And he found that I had another very common and often very serious infection, which can also be spread by a tick called Bartonella. It's, other people know it as cat scratch disease. Could be spread by many vectors. I don't have cats and I didn't have any interaction with them. This all happened right after the tick bite. So for me, I think that's kind of what it was. And I was in treatment with him for under a year, but I started getting better in about a few months. I started getting better in 2 or 3 months, but I was like way better in 8 months and pretty much stopped treating right under a year.
Very good. Thank you very much for the discussion, and happy for you that you have recovered. How are you doing now? Fully recovered? Any previous lingering symptoms, or you're good?
I would say that probably every 4 months or 5 months, I'll feel something. some symptom, and I will treat for a couple of weeks. I probably treat maybe 3 times a year for 2 weeks. And sometimes I'll just treat with something very benign and simple, like oil of oregano. Sometimes I'll add in 1 antibiotic. Generally speaking, I have been extremely fortunate to have been well for the last like 6 years, right, Steve? Is that approximately?
Yeah, I mean, yeah. You're the expert here.
But, I mean, that's about the amount of time that we've been, well, I met him in the beginning of 2015. So it's been about 6 years that I've been well. But I have flashes of it, and I don't think that these infections are curable. I think that you get to a place where your immune system takes care of the lingering reservoir of infection and you feel better. So I'll take it. I'm okay with treating a couple times a year. I don't think it's a big deal. I am shocked by patients who are so hesitant to do that, because I know that if you don't, you can really spiral into the abyss again. But yeah, that's what I do.
And that is why I had asked you, because I know a lot of patients who are in this situation for years and years and years.
Yeah.
And if they start some medication, the Hirsch reaction or other such things kind of push them back. So thank you very much for your story. Very good that you are feeling better. I want to bring Dr. Phillips in the discussion as well. So Dr. Phillips, welcome once more.
Thank you.
I want to quickly show the audience your talks link here. So KoolBeens, there is a link in the description of this video, and that link is about this MIT sandbox, where Dr. Phillips has talked about chronic Lyme and generally chronic diseases. It's worth a listen. I think you'll take a lot of benefit from that. So this is another thing. So going back to Dr. Phillips, so tell us a little bit, when Dana reached out to you, where was she at in her symptoms, and what was your approach?
So she wasn't as sick as my sickest patient, certainly, but she was relatively symptomatic. She had some involvement with heart failure, and I typically get heart failure patients to markedly improve. I haven't had any heart failure patients that haven't gotten better yet under our care. So I wasn't really very concerned about that. And I knew she would get better from the beginning, because she was, you can tell when patients have a trend at the beginning. It's just that most patients start to feel worse for the first couple of months, and it's kind of harrowing for them if they don't know what the long-term plan will look like, because who's gone through this before, right? I mean, it's always new to a new patient, but when you've seen so many cases like this, I was very confident that she'd get better even from the beginning.
Very good. Thank you very much. So if you're comfortable, could I switch the discussion towards the more contemporary issues, for example, long COVID, and how do you see the similarities, the differences, the management approaches? There are so many questions, and there are so many people who are suffering.
Sure.
And I think that just like there are so many people suffering with Lyme and other chronic diseases. So let me start with this question from Dr. Phillips. How do you compare and contrast long COVID with chronic diseases that you have managed in the past?
So that talk that you referenced at MIT is actually the first academic PowerPoint that I've given where I've actually looked at the overlap between Lyme and long COVID, and it's kind of striking, really. You hear all the time, wow, the symptoms of these chronic infections like Lyme and Bartonella are so eerily similar to long COVID. And then you say, is that because there's only so many immunologic pathways that our bodies can take when we're fighting chronic infections? I do firmly believe that, well, it's not a belief, it's a fact. I mean, it's been proven already that the virus that causes COVID can stick around far longer in the body than people realize. Is it the virus itself that's causing these symptoms of long COVID? Is it setting up an immunologic situation where other pre-existing infections that were previously asymptomatic have then kind of shown their heads? So people sometimes don't realize that the asymptomatic infection rate with things like Lyme and Bartonella and other infections is between 8 and 12%. in just not Lyme endemic areas that are stereotypically Lyme endemic, but all around the world, even in places like Western Europe, you see, endemicity of Lyme where it's upwards of 30% of the population test positive. They're healthy people. And what if these people get a bad infection? So way before COVID came around, I would have patients come in not saying, like Dana's case where it was so obviously erythema migrans, but they would come in and say, wow, I had the worst flu. It really knocked me on my butt. And ever since then, I started developing one symptom after the other, and that was the beginning of it. They can trace it to an infection. It's very easy to think, well, I wonder if influenza is causing your chronic symptoms, or what did influenza set up? So, like I said, where's there's evidence that SARS-CoV-2 can persist longer in the body, and obviously there's evidence of thrombotic issues with many patients with long COVID. There's also an overlap. Like, I don't know if anyone's heard of the symptom of internal vibration sensations with long COVID, but that is such an unusual symptom. It's such a weird symptom that I've been hearing for years. I hear it every day, at least 3 or 4 times a day. And it's a symptom that I see in my patients. So is it a coincidence that long COVID patients get this? I can tell you that my personal practice has been closed for some time, but I have 3 nurse practitioners that are taking new patients, and they are treating patients with chronic illness. Some come, they're coming and getting, having this diagnosis of long COVID, and they're working them up for underlying infections and finding evidence of these infections and treating them. These patients are responding typically like we would treat a chronic Lyme patient, and they're improving. So I do think that stirring up the pot of a previously asymptomatic infection does contribute to some cases. The patients with primarily thrombotic issues, I would say that, there's a strong element, the persistence of the virus that's causing that. It's relatively rare to see thrombosis in my chronic illness population before this. I've seen it. I've seen patients with, spontaneous pulmonary emboli and even DIC and very bizarre immuno kind of thrombotic issues, but it's relatively rare. We even had, I remember a family came to see me, and I didn't see the kids, but I saw the parents. They all got sick at the same time when they went like wild strawberry picking. And one of the children was 10 years old. He wasn't a patient, but he had 2 strokes. So, rarely these infections can cause thrombotic issues in children even. And but yeah, that's what we've seen. I do believe that these patients with long COVID should get a workup for underlying other infections because you have a target.
Yeah. I just saw somebody mention the vibrations, and I had that too. And I still get that sometimes, actually. We were just talking, Steve and I were just talking about
and
this.
I've had it too. It's the craziest thing because it and if you tell it to a doctor, they all say the same thing. You must be anxious. Well, when I get it, when most patients get it, kind of, in the morning, it will wake me up, vibrating, waking me up. So it's clearly not anxiety, when you're sound asleep. And I had a patient call the police thinking there was an earthquake. He felt like his bed was vibrating that strongly.
Didn't I say that to you yesterday when I was on my walk and we were talking, and I said, I literally, it feels like there's an earthquake waking me in the morning.
Yeah.
I literally said that to you. I can't believe you had another person say the same thing. That's funny.
Mm-hmm.
And I have actually heard this from long COVID patients that they call in, and sometimes from here, I practice not here in the US, but in Pakistan. But even from sometimes here, people are looking for reference to say, you talk with the doctors, some people who may be able to help, can you tell us? And one common thing that I hear for long COVID is my fingers and my hand, they feel trembling and vibrations, and I do not know what is going on. And people are astonished with that. They have never had that feeling before of vibration in the body.
Yeah.
So tell me this. I have a question, and I think you touched on this. Is long COVID by itself a disease, plus it is possible that it is unmasking or triggering Lyme disease or others as well?
This is what I'm thinking. No one seems to be talking about this really. And it's something that I got suspicious of as soon as somebody sent me, we were working with Survivor Corps, during this whole time, and, just interacting with them and getting to know some of their long COVID patients and their surveys that they do, and looking at the symptom list. I was like, this is eerie. This overlaps 97%, let's say, with what I see in my patients every day. And how much is a separate virus? But I have to say, like I said, there could be many, infections that cause the same net immunologic pathway. But just because of my prior experience, if I hadn't been doing this for so long and have so many patients come in, develop chronic, flares of underlying stuff with other viral infections, I would probably have had a higher threshold to believe that it's possible. But I've been seeing it for a really long time, and I had predicted it way before we saw in the practice our first long COVID patient. I said, I bet this is what's going on, and to some extent. I'm not saying everybody, but to some.
Got it. Thank you very much. I want to ask this question from Dana, this next question. So Dana, you did a significant thing for all of us, and that is you participated and put together this book, Chronic.
Mm-hmm.
In the context of chronic or Lyme or chronic diseases, in tick-borne or vector-borne diseases, what is your current mission? What are you doing nowadays with Dr. Stephen Phillips? Without him, how are you continuing?
Yeah, well, I mean, I still have a little bit of a hand in music, but right now we are actually working on, we're trying to finish up some fun. Steve, can I talk about what we're our next?
Yeah, I can fill in the details if you like.
Okay. So we
scientifically stumped or whatever.
Oh, well, I'm talking about our next endeavor.
That next endeavor. Sorry, we have several things on the horizon.
Well, we have a little biotech company, and we're moving forward with a. Steve can comment on that. Okay, so
Yeah,
I'll let you talk about the science there.
Okay.
But the other thing is that we're working on a TV special for PBS, and we're finishing raising first round of funding sponsors for that. So that's really, really exciting because the producers loved our book Chronic and felt it was a really important topic, and bringing in the topic of long COVID. And I'm just deeply involved in the COVID literature and community and talking to scientists. And Steve and I have meetings with people that are studying COVID all the time. And we're trying to find out like the truth of what's going on and try to solve patients, what's helping patients. And we're seeing deeply the overlap between, as he said, chronic Lyme and long COVID, and the denial of any helpful treatments for people with long COVID. Like we are, I'm speaking for myself, I'm convinced that a lot of the ongoing symptoms are persistent infection, whether it's COVID or COVID plus other things, as Steve would say, waking the beast, bringing up other latent infections. There's no question in my mind that's going on. I'm just praying that this research will be brought forth and that there will be treatments. And like, I was very lucky, because I got better, but I got better with a very controversial treatment, which was not very controversial in reality. I mean, it's ridiculous, but these things get discredited. So like we see, sorry to go off on a tangent, but we see all these cheap generic drugs. Take fluvoxamine, for example. There was a piece on 60 Minutes in March 2021. Okay, so 9 months ago or so, and about it being like a big hopeful drug, and there's great data on it, and I think it confers something like a 90% mortality benefit. You two could comment on that further, but where is it? Why isn't every doctor treating with it? Why is it controversial to treat with a cheap generic drug that costs $4 rather than treating with remdesivir, which is dangerous and doesn't work, and you give it to this antiviral in the hospital to people when they're half dead and the virus has stopped replicating? Like, I don't understand why nobody's making a big fuss over this subject besides us. But this is a hill I'm going to die on. You got to treat patients early. And that's the only reason I'm here right now, is because I didn't listen to the party line. I knew they were wrong. And I'm telling you again, they're wrong about COVID, and they're wrong about long COVID. And you should advocate for treatment. And you should advocate to find out what's causing your symptoms, and then to find doctors that will actually treat the underlying cause of those symptoms, whether that is with antivirals for COVID, and we'll see what is on the horizon, or other latent infections that you could treat, like Lyme and Bartonella.
So you hit on a very important thing. And even today, I was speaking with someone who were suffering with symptoms after their acute COVID disease.
Mm,
So let's say they were in long COVID.
mm,
And the experience was that whichever doctor they were going to,
mhm.
including cardiologist,
Uh-huh.
the message to them was, we don't think there is anything wrong. We've done all the tests that we could have done.
Right.
You are fine. Maybe it is anxiety. Maybe you are stressed. Maybe it is just some more days would pass by and you'll be okay. And that person was literally crying, not because he had symptoms. In addition to the symptoms, nobody was listening to him.
Right.
Yeah,
So he didn't
been
have
there.
hope.
Yeah.
How are you, sir? So you are, of course, in the midst of the chronic diseases and their management, and you are the leaders in that area with this book and with your work. How are you seeing it? Do you see that doctors are actually, what percentage do you think? 5%, 10%, 1%, 2%? What is the help patients getting?
In terms of chronic infections that are vector-borne or long
Or
COVID,
the long COVID?
I think the doctors don't take a strong position so much about long COVID. It's you have two categories really. You have most of the doctors that say that it's in patients' heads and kind of de-stress. They don't really believe in it, and the others that say, I think there may be something to this, but I have no idea how to help you. And you have a very, very small percentage that say, let's try this, this, and this. And virtually nobody is doing what I had just kind of recommended. They're looking for underlying vector-borne infections. But when you mentioned about the person that you had spoken to that's so frustrated because the doctors, they don't find anything on their tests, and then they say, well, there's nothing wrong with you. It's more appropriate really just to say we don't find anything on our tests. You know, when I was really, really sick, I had severe vertigo, was one of my 50 symptoms. And it was severe enough to the point that the bed was spinning for a month on end, and I was vomiting a bucket 10 times a day. And when I got well enough to go to an ENT doctor for vertigo testing, I remember texting a friend from the waiting room saying, I think I'm going to fall off my chair. I can't wait in this waiting room anymore because the room is spinning. And the tests were normal. And I ended up vomiting on the way home. And I remember thinking, you know, I can understand how a patient who is more kind of impacted by doctors may cry leaving that visit because they think, well, the tests don't show anything. The doctor can't find anything. There must be something wrong with me. Not to say, wait a second, you know, medical science is really not as advanced as I'm hoping that it would be. And people just realize that doctors are humans with all the mistakes that are prone to our species. And I would tell that person that you spoke to believe in him or herself, you know, and the experience that he or she is going through.
Doctors
then-
follow guidelines. Doctors, sorry, no, just doctors follow guidelines. They don't think critically as a group. Of course, there are outliers. You two are both outliers. Thank God for you, but you're rare. And I would just, you know, advocate for patients and for doctors to hear this message. Think critically. When something doesn't feel right, keep looking. And doctors are missing these patterns. You know, if you've got 10 people that came back from the Hamptons this summer that have fibromyalgia, what do you think might be causing that? I mean, seriously, we have to start thinking along these lines of these seeing these patterns. I see them. I'm not a doctor, but I've diagnosed a lot of people in my life. You know, I've sent them for, you know, to the right clinician to get the diagnosis that actually got them better. And most of the time it's been an underlying infection. You know, if I can see it, I know that other doctors and other patients can see it too.
And this is what I wanted to actually then reach this point to say, and Dana, you've already touched on it. Dr. Phillips, you touched on it as well. I want to expand a little more on that. And that is, imagine I am a doctor and a patient comes to me and they say, I have this vibration in my hands or my body and it's a weird sensation. Or sometimes patients say that I think everything is going very fast and I cannot process it. Imagine that is happening, and I, as a doctor, have sincerely not seen this kind of a patient or symptoms before. At this time, when long COVID is becoming prevalent, previous diseases are already there, what advice will you give to a medical doctor that they can start thinking and becoming more knowledgeable about it? What path should they take? What should I do if I am actually not well prepared, but I want to?
I mean, there is there's a whole standard panel that we check in the office. I don't know how, I think it has to start with medical school to see, like I was taught in med school that breakaway weakness, also called giveaway weakness, was psychiatric. And for your, viewers, breakaway or giveaway, depending how old the doctor is, different terms. But like dropping things out of your hand and then being able to pick them up, or knees buckling, sometimes to the point of people falling down, and then getting up, like intermittent paralysis. We're told that that's psychiatric because they can't find a specific pathway. The EMG testing is normal. MRIs don't line up. And again, it's one of these situations where doctors don't find something and then they default to psychiatric. And I started noticing patterns with that a long time ago with Bartonellosis. And I do think that that's a very specific feature of Bartonellosis. It's like the mirror image of myoclonus. Like myoclonus is a movement disorder where, some people move like +1, and then breakaway weakness is like the mirror image of that. It's like a -1 movement. And so that's just bringing up another kind of weird symptom that doctors don't understand, a weird sign, that breakaway weakness. And the internal vibration sensations, I've had the pleasure of having about 3 or 4 neurologists as patients over the years. And I've always said to them, hey, what causes breakaway weakness or giveaway weakness? And they're always like, well, we send those patients to psychiatrists. And I've kind of been able to help educate them. But how do you educate people on a larger scale unless in medical schools start taking this seriously and inviting people to speak, doctors to speak about their experiences in kind of fields that are less explored, because the patients clearly are falling through the cracks. They're not getting care, and they're frankly suffering abuse a lot of times. I have a patient from a few years back. I remember she said she went to her neurologist. I said, how'd the visit go? The neurologist said, and she told the neurologist that she responded to several courses of antibiotics and then relapsed with her neurologic symptoms. The neurologist slammed her fist down on the table and screamed, there's no such thing as chronic Lyme. And if you say it again, I'm going to discharge you from my practice. And she yelled at her. And I said, so what did you do? The patient, she said, I just started crying. I was like, this is like so wrong on so many levels. It's like, this is not why we went to med school. This is not how, what is going on here? And I think that, like I said, I think we have to be trained better. And I don't claim to know how to change the system, but the system is clearly broken and needs some type of reform. I always said that medical training, I wasn't crazy about the way it was done, because like I went to a business school, I went to Wharton before I went to med school. And I just tweeted something about this, because there they teach you how to think. And then in med school, they kind of teach you what to think. And I think that they should just give you skills to have an open, like stay with the open mind that you started out with. But I think as doctors become more and more focally trained, become more and more closed-minded, which is a danger. It's good for expediency, but it's bad in many ways, because we end up not listening, and we get most of our information from listening to the patient.
So then I have a question, and Dana, please jump in if you like as well. This is an interesting question which I have been grappling with, and that is this. There are doctors who then go out on a limb, try to figure out maybe this is something, there is something, it is not psychiatric, it is not just the patient being anxious or stressed or making up stuff. Maybe there is something, and then they go out and try to figure out solutions. And what I'm seeing, for example, in the COVID era, that there is a strong and harsh repercussion that occurs. So that, I think, motivates a doctor to stay within their protocols and algorithms and within their structure in which they are thriving. How do they come out of that and take risks, which could be risks to even their license?
Is that a question for Dana? Yeah. Okay.
Yeah,
so let's start with Dana, and then we'll ask Dr. Phillips as well.
Yeah, I would say that, the doctors that I think are the best doctors, the doctors that I trust the most, are the ones who are willing. Look, it's totally legal for doctors to prescribe drugs that are off label. So fluvoxamine is a drug for depression and anxiety and OCD and stuff. But you can use it off label now that we know it works well for COVID. Like, you can use it off label. I don't really know why that would be flagged. There are other things that are non-prescription things that can help patients with COVID. We know that there's bromhexine and vitamin D, and there's a Pepsid even. There's a list of things that have been published to help. So I just don't understand the dogma. Like, I don't understand if you bring your doctor this data, say they haven't seen it yet, and you say, hey, doc, I'm pretty sick. Can we try this? I don't understand what the drawback is. We know a lot about safe, generic, cheap, long-standing drugs. We don't know a lot about these new things that are coming out. We don't know a lot about remdesivir. But we know a hell of a lot about the other drugs that have come and been extremely controversial and called bad names like horse paste. I mean, Nobel Prize winning drugs. It's just crazy for us to watch. But I would say that it's also quite predictable, because this is exactly what happened in Lyme. It's just worse because it's now on a global scale. And now doctors are being publicly shamed and ridiculed, and their careers are being totally demolished because they're standing up for their patients. It's crazy. I could, I don't know what to do with myself. I think it's so sad and such a crime against humanity. What do you, Steve, what can doctors do?
Well, I'm struck by a few things. I mean, to speak about fluvoxamine, so there's been a recent large randomized control trial that was stopped early because it surpassed the preset kind of limit for what they considered superiority. And so at that point, they considered it unethical to deprive the placebo group of the fluvoxamine. That's how good it worked. And it had a 91% reduction in mortality. And I just tweeted about this because it is completely shameful, in my opinion, that the NIH has not updated their fluvoxamine webpage since April 2021 and does not take this information and run with it. And this should be immediately trickled down to physicians. This should be immediately part of like CME education, and say this is worth a trial. And they should take this and just run with it. And instead, there's just either crickets or you get this campaign. And if I saw something like, there's so many studies on vitamin D, with COVID, and as there is with so many even seasonal respiratory viruses and such. But if I saw a PSA on television that said, check with your doctor and keep your vitamin D level between 50 and 60, something reasonable like this, and your mortality with COVID is going to be reduced, I would think, okay, at least they're doing something that makes sense. But when I see them only backing the drugs that are profitable and either ignoring or demonizing the drugs that are inexpensive, I have zero faith that the motivations are anything but profit seeking at this point.
Yeah.
And I don't care if a big pharmaceutical company makes $1 billion on an amazing safe drug. I care about the people who are suffering and developing chronic illness and who are dying during the time that these new drugs are developed, when old, accepted, safe, cheap options that are going to save people's lives are out there and being dismissed and ridiculed.
This pandemic would have a much different tenor if we had early outpatient treatment. So there's all this talk about hospitals being overwhelmed right now. Okay, we're in the middle of our 4th or 5th surge. I can't even keep track. More people are vaccinated now than ever. We still have no outpatient early treatment except monoclonal antibodies, which are notoriously hard to get early enough. You have to have a positive PCR most of the time. And we need something that people can take at home as soon as they get sick. They can take a rapid antigen test and they can pop an antiviral or pop a cocktail of drugs and know that they're going to have a pretty good chance of staying out of the hospital and dying, and letting this virus run wild through their bodies and ruin every organ, because that's what this thing can do. And I just don't think people totally appreciate the crime that is the dismissal and the ignoring of the importance of early outpatient treatment and prophylaxis. And to me, this is way, way overdue. And I don't understand why it hasn't been done. And I don't understand why nobody is talking about it except a couple of us.
Your issue, your question, sorry to interrupt, it was about how can you practice though in this area where using off-label things and kind of in the fear of being ostracized in some way or looked down on. I mean, I just do what I feel is right for my patients because this is I could have just stayed on Wall Street. I didn't have to go to med school. I went to med school for a certain reason, and it was a scientific reason. It wasn't to cover my own butt all the time. I mean, in my practice, we are very, very buttoned up. We run it like, it's a very tight ship, but it's also super casual and relaxed for the patient benefit. And we do things as safely as possible. And that's the way we run it. And in 25 years, seriously, knock wood, things have been okay. So I do think there's a lot of heterogeneity among doctors that take on these complex problems, and they all treat differently. And there are some of the things that I see doctors use that frankly scare me that I wouldn't use. But they do use them and they have comfort levels with them. And they probably think that the way that I treat is kind of boring. But my patients do generally well. And I think I have a decent safety profile.
Agreed. And thank you very much for this. You can call me naive that when I started seeing various studies that would talk about supplements levels, various drugs that could be useful, I was naive probably to start thinking, man, we can get out of this thing so easily, that we found it. And I remember I used to tell my wife that it looks like for this poison, the virus, the SARS-CoV-2, there is an antidote as well. It came with an antidote, we know. And of course, we are 2 years into it with lots of damage and lots of, I think everybody knows what's going on. With fluvoxamine. So ivermectin became quite tainted, and here is a study that is getting withdrawn, and that fluvoxamine actually came in with a good study, with a good result, and many mainstream media has actually carried that news as well. And even then, so when that happened, I said, all right, at least fluvoxamine will now be the one. And even that has never appeared on the surface, which is strange for me to observe.
I'm waiting for them to start talking about side effects of fluvoxamine because it is a drug that you can pick on because it has some cardiac, potential interactions and how they, demonize hydroxychloroquine. So, with ivermectin, at least it's such a low side effect drug. It was very hard for them to pick on it, but in my experience, it didn't work quite as well for Delta as it did for Alpha. I still think that it's helpful and has a place, so it should obviously work better. Yeah.
Got it. Thank you very much. So so we are 46 minutes into the discussion, but I think that we are just starting. So I know that you're on the East Coast. It is late. Would you mind if we take a few questions as well from the KoolBeens and from Twitter?
Sure.
Okay, excellent. So I'm going to go to Twitter, and KoolBeens who are watching, there are a lot of folks who are watching. Please, if you have a question, write QQQ or question mark with a question. Please don't request for personal advice because none of us can do that. None of us should do that. We are sitting in an online panel. So, but please ask the questions that you may have around the chronic diseases, Lyme, the book, their journeys of our panel today, or long COVID. And I'm going to meanwhile go and look at some of the questions from Twitter. So there's a question from Amy. She says, ask Dr. Phillips, how is he generally treating long COVID? And I used to generally say that the type of management I do, early and aggressive management, I don't have patients who are long COVID, or maybe a couple of them. So she said, don't let him say that you don't have patients who are long COVID. So how do you approach long COVID?
I could say we in the practice because it's actually true. I don't have many long COVID patients, but we collected a few. Some patients have now seen my nurse practitioners who come kind of de novo, and then we did have one patient come to see me very late into it, and despite a treatment that I would have given early, did develop long COVID. And we have another patient who was treated early and did very well, and the character of her Bartonellosis changed markedly. And we thought it really was long COVID. And she responded beautifully. This was during Alpha strain. It wasn't even Delta. And she responded so well to ivermectin and various other agents. And she basically had a very mild case, but then her neuropathic situation, which was part of her illness, changed so dramatically that I wasn't sure, is this long COVID or is this something else? And we started, we did evaluations for responses to things like Ivermectin and other things that we'd want to see if she gets an antiviral response. And it didn't change her situation, but we added and kind of modified her treatment for Bartonellosis. She got a major Herxheimer reaction, and then thankfully has now started improving. So, or has been improving for some time. So in her case, what another doctor may have thought was long COVID, because it did come after COVID, seems to have been clearly a change in her Bartonella, because she wasn't really treated maximally beforehand. But in the people that come de novo who have a diagnosis of long COVID, we're doing workups for both coagulopathy, things like D-dimers, and we're also, other clotting parameters, and we're also looking for evidence of underlying kind of chronic infections, things that are vector-borne mainly, and some chronic infections that are not vector-borne as well. And we're finding that these patients respond to antimicrobials the same way that our patients who have had things like chronic Lyme and Bartonella and chronic Q fever and things like this. And the treatments are different depending on what we find. But that's how we're approaching it, to try and use the safest drugs first and to look for evidence that points toward persistence of the virus and evidence that points toward other infections. I wish that we had better tests to try and detect persistence of the virus. Like we've sent off stool samples for PCRs. We haven't had any positives. No one's gone for intestinal biopsies. These invasive tests are just not something that people want to do, and I don't blame them. I wouldn't be rushing to send them off. But I always wonder, should we have done more stool PCRs at the beginning rather than always focusing on just the swabs, the nasal swabs? Maybe that would have given us some insights.
Very interesting. Very interesting. Thank you very much. So I have a question, one more question on the Twitter side, and that is, it is from QZ. What does Dr. Philip think of Bruce Patterson's work and protocol, and would it work in long Lyme? So are you aware of the Dr. Patterson and Dr.
Yes, somewhat. I mean, I have, I know peripherally patients who've been to him and raved and said that it really was very, very helpful. The thing is, I don't know if there's, so I'd like to go after chronic, what we call Lyme plus in the book, these chronic infections, by getting at their source. And I think a lot of the stuff that he uses is kind of immunologic treatments. So I like to say that if we get rid of the source, the immunologic aspects of things follow and they settle down. Because I know that when I was at my sickest, I was offered by 3 different rheumatologists drugs to just focus on the immune response. And I just didn't want to go there and leave the active infection alone. So if we think that someone has evidence of chronic Lyme, you say, how do you know these things are so difficult to detect? Luckily or unluckily, is depending on your perspective, the presence of Herxheimer reactions is actually very, very important in defining when someone is still sick. And when we have evidence that these people still have, infections that cause Herxheimer reactions, I wouldn't personally advise to go down purely an immunosuppressive or immunotherapeutic route.
Got it. So Michelle Wall says, is there a correlation between an increase in Lyme disease and a decrease in correct medicine and treatment from insurance companies and physicians?
A correlation between an increase in Lyme and a decrease in correct medicine and treatment. You mean an increase prevalence in the country?
So maybe less support for chronic diseases resulting in chronic diseases increasing?
Yeah,
So
I think that's what she means, I think.
So say that one more time. I'm sorry, I did not get
so
this.
how are the insurance? So I'm sure that you get chronic disease patients. Do you get good support from the insurance companies?
Yeah, generally we don't have a problem with insurance companies, believe it or not. I know it sounds hard to believe. We don't use any intravenous antibiotics in my practice. The medicines are so cheap, they're generic, so insurance companies, it's not much of a thing. We do extensive blood test panels when people come in. So we use 8% of the tests are done at in-network laboratories. So whether it's Quest or LabCorp, there are problems though if people have, let's say, large deductibles. So if people have, some of these insurance programs are so bad these days. It never used to be like 15 years ago. But when you see these insurance programs where $7,500 deductible and everything goes toward the deductible, including labs, those are terrible programs. So, but barring that, if it's a situation where people can go to Quest or LabCorp or BioReference and pay $25 or something, they do quite well. And then we'll send out for Lyme testing, we send out to Stony Brook, and for Bartonella testing, we'll send out to Galaxy. And Stony Brook is usually covered by most insurance, and Galaxy initial, screening test for Bartonella Henselae, I think it's like $150 or $125. So we're not talking big expenses to get adequately tested. So.
Got it. So I'm going to ask a question from Dana. So Dana, you were talking about in the beginning, a little earlier, vitamin D and other drugs. So as a non-medical person, how did you come about knowing this when generally these talks and these studies are not in the mainstream media? Did you have to actively go find them? What was your process of learning and educating yourself about COVID?
I'm very curious. So I'm always looking. I mean, after what I went through with Lyme and having to find my own answers from like the depths of illness and despair, I had a very strange reminiscent feeling when all this began. And I'm very lucky that I have people like Steve in my life who we speak, very, very frequently. And I have a lot of physician and scientist friends. And I watch podcasts like yours. I've been following, I'm in various listservs and groups, and I just pay attention, and I kind of just do the things that make sense. And I check them out with Steve, and I check them out with friends that are working with COVID patients. I have medical friends that treat COVID patients who told me, long ago, who are like treating in hospitals, my patients that are on SSRIs that have vitamin D levels at, 70 or 80, and who are not obese are doing much better than the ones that don't have those, that are obese or don't have those levels and are not on these drugs. So they were seeing correlations early on. And I think that I just paid attention to that. And look, I'm not saying anything is a panacea. I don't think anything is a panacea with this virus, and I deeply respect it. I have no illusions that it's a cold, that it is minor. I mean, my whole life was upended by it like many others. And I would say I take it more seriously than most people because I already was in heart failure. And I know what it's like to lose everything that you love about your life because you were derailed by chronic illness and to come back from it. And I don't want to do it again. So that's why I sought this information. Agreed.
Thank you very much for this. Dr. Phillips, I have a question here, and totally up to you to respond or not. LEG says, please advise what a cancer patient must do to improve his immune system, keeping in mind the current COVID situation. So I want to put the disclaimer out. LEG, we cannot provide a personal advice at all. So this is more of an educational discussion, not an advice.
I mean, so in my practice, we don't treat cancer patients. That's not the chronic illness that we do treat. But we also look at both sides of the equation when we're treating patients. And one is the antimicrobial side to get rid of chronic infections. And the other side is to restore immune function. And people don't realize, and I think I may have said this in prior talks with you guys, that most of the chronic bacterial infections induce something called anergy, which is like spelled like energy with an A, and it's a focal dysfunction of the immune response. And then the parasitic infections, it's more of a global hit to the immune response. But either way, the immune system suffers from chronic infections, and some people realize this and some people don't realize this. And there are strategies to reverse that. Some things are very, very simple. Like there's evidence that vitamin C, which is so basic, and a lot of doctors poo-poo it, but there's evidence that vitamin C kind of restores immune function under periods of immune, stress and immune tolerance, which is another way for, describing energy. And some of the chemicals that are in mushrooms, beta-glucans, can also kind of restore immune function. And epidemiologic evidence shows that consumption of mushrooms is associated with less cancer, I think because of increased immune surveillance. And another thing that we use in the practice is low-dose naltrexone. And naltrexone is a medication that's in high doses is used for narcotic dependence and narcotic overdose, but in low doses, it's shown to be an immune potentiator and immune modulator. And then lastly, and we're talking very low doses, like roughly 1/50th of the doses that are used for narcotic dependence. And lastly, ivermectin. I've been using ivermectin in my practice for a decade before COVID came around. I have so much experience with ivermectin, and it's been so helpful for my patients. And I have a patient now who was so disabled with a horrible chronic fatigue syndrome diagnosis, which in itself is such a heterogeneous diagnosis, because some people get diagnosed with CFS, ME/CFS, and they're really highly functioning. Other people are completely bedbound, like this person was. And we took her from complete disability, where she couldn't even lift her head up off the pillow, to full functionality and full-time work. And with her, it was ivermectin that helped her to get over her infection, and she still takes it, from time to time. And that her pharmacy cut her off because of the COVID politics surrounding ivermectin, and it's just such a sin, And I said to the pharmacy people, I was like, she's been on this since 2015, right? I mean, like, can you check the record? And I was like, I said, I tried to relate this whole story, and it doesn't really matter. They're just, this blanket axe came down on ivermectin where they just stopped approving it. And it's for the patients whose lives it's turned around, this COVID politics has really gotten in the way.
And not only the blanket axe, what I felt really bad about, and I still do, is how this drug, ivermectin, was picked up, put in the mainstream media, and I think deliberately bad-mouthed, because all the mainstream media and all the comedians and everybody came out all together to start calling it horse dewormer.
Right.
Even yesterday, I was watching a comedy show, and they had made up a small, tiny snippet of some holiday gift as a junior horse dewormer. And I was thinking the amount of disservice that they are doing by bad mouthing. You could say, we don't believe in this drug for COVID. Don't use it for COVID. We don't recommend it. We stop. Don't do it. That may be a message. But generally calling it a horse dewormer, this drug is used by for so many other reasons, and they have just tainted it all for everyone.
It was so orchestrated. It was the FDA tweet with horse paste, and it all happened at the same time. All the pharmacies started rejecting it, all the insurance companies, within 2 weeks. So nobody can tell me that it wasn't this like intricately planned PR campaign that was very, very successful, unfortunately. And, and I think to myself, for whatever value it has or does not have for COVID, it has some value. And how many lives are they going to cost us all, whether from mortality or from chronic illness, because of this lust for profit? And that's the only way that I can explain this, because there is no reason not to let medical doctors use their best judgment with an extremely safe, well-established, cheap drug that in something like 60 studies, at least for COVID, has benefit. And then all these side benefits that we know that it has for so many years. So
I think people have to understand, I'm sorry, Dr. Bean. I think people really have to understand that pharma's push to sell new patented drugs has been going on forever. So this is also not a surprise to us, although it's a great disappointment to us to see this in COVID, because the stakes are so high. Like, it's absolutely devastating to see what it's done to people, to deny them the most innocuous basic drugs that are old, cheap, and generic, just to see if they can help. because they're developing new patented drugs. And the only way to get people to use shiny new patented drugs is to not have anything that's cheap and generic and old. And there's really, we say this all the time, there's no money in cures. There's money in chronic, incapacitating, debilitating illness. So if you keep people on a merry-go-round of drugs for the rest of their life, immune suppressants like Enbrel and psychiatric drugs, because let's also be clear that infections cause psychiatric diseases and neurologic diseases. So when patients are being told it's in your head, you're anxious, yeah, because I have a brain infection that's causing my brain to be inflamed, and for me to have these symptoms as a result of the infection, not because I'm neurotic, not because I'm crazy, but because I have a brain infection. So I think this needs to be made ultra clear for everybody watching here. This information really is crucial. It's like I live and die by the truth of this, because if we don't know that this is possible, we will walk out gaslighted, totally gaslighted. And I would say this has been the most successful propaganda campaign I've ever seen. And I never thought I would find myself, I was the most mainstream TV, liberal, whatever, television watcher. And now I can't watch anything because I'm just being bombarded with propaganda and being gaslighted. And it's literally nauseating, because for me, I'm going to do what I'm going to do regardless of what I'm being told by people like that, gaslighting the country. Because I'm very lucky in that I have other people telling me what, other things that I can do. Okay. So I don't care about myself. I care about my parents hearing it. I care about my family and friends hearing it. I care about all the patients that I hear from that are totally, totally crippled and debilitated now by long COVID or by chronic Lyme, because they couldn't get a basic treatment because their doctor was told that it's a horse dewormer, or that they would lose their license. I mean, that to me is just a crime against humanity.
I totally agree with that. And I have mentioned this in my talks once earlier. And I would say this again for anyone who is interested in doing some DuckDuckGo search or Google search. A few months earlier, after June, you would see that in 1 week, there was India's ICMR stepping back from Ivermectin. At the same time, there was Australia stepping back and banning Ivermectin. Within the same week, there were mainstream medias. I can name the folks who started calling it names. Comedians started talking, and all the talking points were the same.
Yes.
To me, it seemed like there was a talking point structure that was fed to various these organizations to say, make sure that your hosts talk about this thing in this way. And then they all started speaking the same exact thing. And they kept going for a couple of months. At the end of a couple of months, there was an event. I alluded to that before as well. When that event happened, all of this then calmed down as well. Now there are some remnants that are still there. For example, yesterday's snippet. But to me, it was amazing and shocking to see how widespread and how powerful the reach was.
Yes.
Yes, it's absolutely terrifying. I mean, when you let politics and private industry control the narrative, we're science, it's all squeezed out. we're at patients' rights and rights to good health. Dana had mentioned briefly about the biotech effort that we have. So just to flesh on that, it's nothing is really public, but just so no one's wondering. When I was at my sickest, I was in bed for 2 years and had a lot of time on my hands. And I came up with an idea for a potential new drug candidate for some of these very difficult to eradicate infections, not just Lyme and Bartonella, but it has potential applications for others as well. And I first presented it to our, may he rest in peace, our very good friend, Dr. Neil Spector. And he thought it was a really great idea. And then we talked to some specialists at Duke who were in the department, and he said, yeah, it's worth pursuing. And I applied for a grant with the Bay Area Lyme Foundation, who we were very much closely affiliated with. They're pretty much the best organization out there. And They fund amazing, innovative research, and they were generous enough to, choose me to have their Emerging Leader Award. And now we're working with researchers at Stanford University to develop this drug candidate, and we have initial promising, science, but there's nothing to really, publicize. But just to say that people are doing work toward these things behind the scenes. You may not hear of it on a regular basis because things go so slowly when you don't have like NIH funding behind you and it's just private funding. But where people are trying. I spoke to a great researcher today who does amazing animal research at Emory, Monica Embers, and she does some of the best research out there. And there are just some really, really good people that are making inroads and making advancements in these fields. But the time to take to trickle down, if we had real good funding behind this stuff, everything would move at a really much faster pace. But it just seems like the NIH and government authorities have no interest in these very difficult to conquer infections. And like a shared Dana suspicion, like there's no money in cures, there's money in chronic illness. And you get very jaded when you've been doing this for a long time. Yeah. I share that view, actually.
Got it. Thank you very much. So we are 7:10. So thank you very much for your generous time, for your insights. So how about I request for one statement each before we close. And KoolBeens, thank you very much for being here as well. We would have a great weekend. We'll see each other after the weekend on Monday. Dana, any comments? Current situation, COVID, long haul, chronic diseases. What is your approach? What is your message?
Well, the first thing that came into my mind was to tell people really clearly, since our federal officials will not, COVID is airborne. I highly, highly recommend that you all have N95 respirator masks in your arsenal now to wear indoors. We are in the midst of a winter surge that I think is going to be crushing. I think it's going to be as bad or worse as it has been in the last winter. And I really want you to protect yourself from this virus, because what we know so far is that about 50% of people end up with long haul COVID. And this goes for people who were vaccinated and had breakthrough cases. And this also goes for people who had mild or asymptomatic cases that were not vaccinated. So I beg you to not play Russian roulette with your lungs and with your brain and with your health. I really am devastated by what I'm seeing and the patients that I'm hearing from and the young, beautiful lives that have been destroyed. And I really worry for them. So, and there are no answers for this at this point. Okay. So I just want to say, please take care of yourselves and take this pandemic seriously and take this virus seriously until we have a very, very safe and effective, sanctioned by the NIH, because it's going to be really hard for people to get stuff that's not sanctioned by NIH, as we discussed, prophylaxis and early treatment. And it has to be so early because the virus replicates so quickly that within a couple of days before you even know that you're sick, you could already have silent damage that doesn't really show itself for a couple of months. So I just want to say that. Going forward, I'm hoping that the researchers that are working on COVID will seek to help all of the chronic illness patients that are suffering, whether their symptoms come from an underlying pathogen like Lyme, Bartonella, various viruses, including COVID, or something else. There's chemicals in our environment and things like that. I hope that you will earnestly work to find the root cause and help us unravel and treat these patients. Nobody wants to be on antibiotics for years and years and years. So stop complaining about it and find us something better. I don't want to hear it. Then find something better if you don't want us to take it. Right now, we do what we have to do, and we'll continue to do what we have to do to get well, because that's what life is about. We've got to keep moving forward. And I just want to give hope to people that have been in my position where I was sick in heart failure 6 years ago. I thought I was going to die, and I thought I had lost my mind, and I'm back. And I wrote a book with Dr. Phillips, and we have gone all over the place and spoken all over to, thousands and thousands of people. And been able to share our stories of hope, and we hope that everybody stays safe and healthy over the next period of time. Thank you for having us, Dr. Bean.
Thank you very much. Very well said. Thank you. And Dr. Phillips.
Yes, thank you. I want to bring everybody's attention to the fact that we've interviewed, and it's going to be aired on Sunday, I believe the 12th, Sunday evening on our Facebook page. Ross Douthat, he's an opinion columnist for New York Times. He's made it public that I'm his physician, and he went through a very bad case of chronic Lyme, which was devastating, and he wrote a beautifully written book about it, The Deep Places. He's been described as, they said, a poet of pain and hope. It's a really candid experience, kind of memoir about what it's like to go through these horrible infections. In chronic, Dana and I each tell our story, but our stories, were shortened, and that wasn't the whole focus of the book. The focus of the book was on people reading it to try to provide information so that patients can get a path toward getting better. And I do think that it's the most important advice I can give anybody is to trust your gut and the experience that you're going through. And when something doesn't make sense to you, it's okay to ask your doctor why. And if you get a situation where a doctor is ever dismissive or is too rushed to give you an answer that you're comfortable with, then I would seek additional opinions. I appreciate Dr. Bean for inviting us on, and it's been a great experience as always. And I think that your viewership is already, they're in a better position than most because they're looking to sources of information that are varied and innovative, and that's what patients have to do, and they're already doing that. So really the message is, how do you get to the people who all they do is watch MSNBC and that's the only information that they get, and they're getting one narrative and that's it. So I don't know how to reach those people, but I would say that if the people who are watching tonight know somebody who are getting an incomplete picture and they're suffering from chronic symptoms and chronic illness, they should widen their periscope, widen their horizon, and try to uncover information that we can provide and others can provide.
Absolutely. Thank you so much. And I wanted to leave your statements as the last one, but I want to say this once more to the audience. You have been listening to me for 1.5 years. I have never, ever even requested you to go and propagate something. But this is one book, when I read it, I'm repeating it, that I felt that this was something that every child in 8th grade, 5th grade should be taught, should be asked to read. The reason for that is their awareness that I may be in trouble. It may be the start of some chronic thing. I need to go get early aggressive treatment. We all have to be aware of this. So my request to you once more, please read it, buy it, gift it, and go from there. I think this is a must-have book for everyone. So for medical folks, of course, but it should be for everyone. So once again, it is an honor to meet both Dana Parish and Dr. Stephen Phillips, and thank you very much for doing this work, writing this book, putting this in front of us, then having these talks. Thank you very much for being with us today. Hope that we'll have you soon with us once more with your next projects. And KoolBeens, thank you very much for being with us today as well. I'll see you on Monday.
Thank you.
Thank you. Thank you.